Hello, my name is Zed Baig, and this is my case study. For the patient diagnosis and information about the patient, he's an 18-year-old male. Medical diagnosis was an avulsion fracture of the left ischial tuberosity. As far as the medical history, the patient denies any pertinent medical problems. However, he does have a pre-existing condition, which was a previous left hamstring repair. As far as the social history, patient is active in recreational sports and coaches a high school basketball team. As far as his prior level of function, patient is independent with ADLs and was physically active in sports. And home situation, he lives in a 2-story home with his parents. Etiology and manifestations. So an avulsion fracture and a hamstring tendon rupture first occurred during a high school football game, and this was his pre-existing condition that happened a few years ago. The patient recently underwent a left proximal hamstring tendon repair, left sciatic nerve neurolysis, and excision of the left fracture and ischial tuberosity hardware due to the previous hardware coming loose from the initial surgery. The patient has difficulty performing normal ADLs, has increased pain, decreased hamstring strength, and decreased hip and knee range of motion, and the reasons why he was referred for physical therapy. As far as the goals and prognosis goes, the patient will ambulate without an assistive device and have normal progression over the left lower extremity. Patient's goal is to have 50 degrees of left hip external passive range of motion, 110 degrees of left hip flexion passive range of motion, 20 degrees of left hip internal passive range of motion, and 0 degrees of left knee extension passive range of motion and active range of motion, as well as 120 degrees of left knee flexion active range of motion. And then in terms of his strength, goal is to have 5 out of 5 manual muscle strength tests in his left hip abduction, adduction, flexion, extension, external internal rotation, as well as knee flexion and extension. Also, one of the long-term goals is to have no pain and be able to return to sports/recreational activities, ability to perform normal ADLs, and to reduce patient symptoms. As far as the prognosis, the patient has an excellent prognosis and rehabilitation potential. Patient will be able to return to sports and recreational activities within 4 to 6 months post-surgery. As far as the treatment techniques, the first treatment technique was the use of high volt galvanic stimulation on the quads. This technique was used to address reducing edema, promoting wound healing, and neuromuscular reeducation to eventually help with strength. And the patient responded well to the treatment over time, demonstrating a decrease in swelling and promoted wound healing. And the patient also expressed how he felt it was helping him. The treatment technique could be progressed by increasing the duration and intensity of the stimulation, as well as also incorporating a therapeutic exercise while receiving the stimulation. The second treatment technique I used was the use of myofascial decompression with stretching. So myofascial decompression, also known as cupping, is a technique that was used to address the decreased mobility and range of motion of the patient. The patient received myofascial decompression while also performing multiple sets of 30 seconds hamstring stretches. The patient expressed discomfort a few times when it was applied and wanted to know how it was helping. So I noticed my CI had to readjust it a few times to make sure that it was comfortable for the patient. And this treatment technique could be progressed by increasing the amount of myofascial decompression use, along with increasing the sets of the hamstring stretch. And then the third treatment technique used was a single leg stance exercise. So the therapeutic exercise was used to address stability, strength, and balance. It also helped with his ambulation and functional activities. The patient responded well to the treatment and demonstrated improved mental stability, strength, and balance as exercises were progressed throughout the therapy. The patient did have some difficulty maintaining his balance on the Dynadisc, needing the use of hand support the first time he used it. But after the next session, he started to get more comfortable as well. So that's one thing I noticed. And then the patient initially started the exercise using both hand support and was standing on the ground for 10 seconds at a time. And this exercise was progressed later to be able to stand on a Dynadisc with no hand support. And then the sets were increased to 3 for a longer duration of 30 seconds. So what I learned from this patient interaction was that the patient was definitely motivated and eager to improve, but is also apprehensive of progressing some activities due to fear of hurting himself, and was kind of looking to us to make sure that it was, safely progressing him. I also learned the importance of knowing and following the surgery protocol for the therapy to ensure the patient is being progressed accordingly with safety, and the treatment technique and progressions were appropriate for his condition. I also learned that what myofascial decompression now is, how it works, and how it's applied on the patient, and learned how it is important to know how to properly apply the myofascial decompression so that the patient does not feel discomfort. And some of the learning principles and how I performed as a teacher, I used the knowledge of performance when instructing the patient with new exercises to provide feedback during the activity verbally, along with tactile cues to let him know what he was doing wrong and explaining him how to properly perform the activity. And then as the patient became more familiar with the exercise, I started to use knowledge of results to let the patient know how successfully or unsuccessfully he performed the skill, the activity, or the outcome measure. And then I feel that I did well as a teacher providing the feedback, instructing on performing certain techniques, and then providing tactile cues when needed to help aid in his recovery. And then some treatment suggestions from my CI were that she provided suggestions on how to progress the patient, making sure it was safe. So an example of a progression suggestion was changing the surface, closing the patient's eyes, or increasing the resistance to certain exercises. My CI initially helped make sure that I applied the electrodes properly when I was performing the high voltage galvanic stimulation, making sure it was in the proper location and was properly doing the setup and using the eStim on the patient the correct way. Also, my CI said that he is now able to do more progressive exercises, and that his sessions will start to get longer as exercises will continually be added to challenge him. So the CI mentioned it could even be greater than an hour, close to even 2 hours as he progresses more. So systematic review. So an article that I looked at was a systematic review on the effects of high voltage galvanic stimulation on edema after an acute injury. And the evidence of the study suggested treatment parameters using negative polarity, a pulse frequency of 120 pulses, and an intensity of 90% visual motor contraction that may be used to help promote edema reduction. Furthermore, the evidence suggested that the treatment should be administered in either 4 30-minute sessions or a single 180-minute session to achieve suppression of edema. And the majority of the studies used the treatment of treatment parameters, and it proved to be effective in animals. And the literature suggested future research to examine the effects of HVGS in humans and to help guide with clinical practical use. And that completes my case study presentation.